Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hello, I'm Jared Weiss, an Associate Professor of Medicine at Lineberger's Comprehensive Cancer Center at UNC and Vice President here at cancergrace.org. And it's my privilege today to talk to you on updates in small cell lung cancer. Our first major update occurred a few years ago. What you're looking at here are the results of a randomized study looking at standard of care chemotherapy with carboplatin and etoposide, plus either placebo, shown here in gold, or the immunotherapy PD-L1 agent atezolizumab, shown here at blue. Survival curve ticks down every time a patient dies, and what you can see is the blue curve is above the gold curve, representing a 30% survival advantage for the addition of atezolizumab. Progression-free survival curve ticks down every time a patient dies or cancer grows, and what you see here is a smaller but still real improvement in control with the addition of atezolizumab, critically including better control at the tail of the curve, indicating durable control for a small but real proportion of the patients. A similar experiment was conducted with the PD-L1 inhibitor durvalumab, and the results are very similar. So what this means is that the new standard of care in frontline extensive stage small cell is carboplatin, etoposide, and either the immunotherapy drug atezolizumab or the immunotherapy drug durvalumab. Now, a change in frontline can affect what happens in second line. So prior to this data and this shift in standard of care, the options that I tended to offer my second line small cell patients, meaning someone with extensive stage disease that had grown on carboplatin and etoposide, were hospice, a clinical trial, or an immunotherapy drug. But now the immunotherapy drug is used up in frontline. And so that's all that's left, at least in terms of FDA-approved standards, is topotecan. Topotecan is not a well-loved drug amongst those who treat a lot of small cell because it's very toxic and insufficiently active. Enter a new option for second-line small cell, lurbinectedin. Lurbinectedin is a selective inhibitor of oncogenic transcription. Perhaps most importantly, this oncogenic transcription change results in double-stranded DNA breaks, a lot like chemotherapy, but also it appears to have a number of immunomodulatory properties, including taking out tumor-associated macrophages that suppress immune activity against cancer. PFS with lurbinectedin is slightly better than what we expect with topotecan at just shy of 4 months. And survival, again, just better than what we expect with topotecan at 9.3 months. Importantly, these treatment advantages come not at a cost of toxicity, but at less toxicity than what we expect with topotecan. Nonetheless, like all anti-cancer agents, lurbinectedin does still have some warts, and to the extent that it does have side effects, they're mostly hematologic, a lot like chemotherapy. We see neutropenia. These are the cells that fight infection, including results of febrile neutropenia that often lands patients in the hospital, as well anemia and thrombocytopenia, so all the major blood counts. And in addition, the other adverse events that are not blood-related also seem chemo-like: fatigue, nausea, decreased appetite, and vomiting. Speaking of blood counts, the next agent likely to be approved in small cell is trilocycline. So trilocycline is an agent aimed not at improvement of survival, attacking the cancer like most of our agents, but rather is aimed at improving the quality of life in patients receiving chemotherapy for extensive stage small cell. Seen here is a summary of the 3 basic blood types: the neutrophils, the red cells, and the platelets, and their costs, both human and financial, when they go very low. We see very high rates of these side effects and real side effects with some of the treatments, representing an unmet need for our patients. We don't really need data to know that people feel lousy when they're anemic, when their red cells are low, but in case you do, here's some data showing that patients don't feel as well when they're anemic. And I would say in practice, fatigue is the biggest issue. Chemotherapy works by poisoning dividing cells. Most of the healthy cells of the human body don't divide. They sit put and do their job, and so the poison washes right by them. In contrast, the bone marrow progenitors do divide, and that's why they're poisoned by chemotherapy. Trilocycline holds these cells out of cycle, so they're not dividing while the chemo washes by, trying to preserve a variety of cell types. 3 randomized phase 2 studies were conducted to look at the efficacy of trilocycline. The first was the O2 trial, carboplatin etoposide plus or minus. While this study was being conducted, the standard of care changed, as I showed you on the first slide. So the next study looked at carboplatin, etoposide, and atezolizumab with or without. And finally, the final study here looked at the addition to topotecan to show if the drug could help in a bone marrow that was already harmed by chemotherapy. Here's the pooled data from the 3 studies. Each of the individual ones looks very similar. We see the primary endpoint, severe neutropenia. I'll remind you, these are the cells that protect against infection, going from 53 to 11%. In terms of febrile neutropenia, the event that often lands patients in the hospital, from 9 to 3%. And as well, a lot of the elements of supportive care that we do decreased, as you would expect. But the critical question is, did patients feel better? There were robust quality of life measures. Looked at from a variety of angles, patients did feel better. I would argue most critical here is fatigue, which was a whole lot better in trilocycline-treated patients. Looking down the pike, I think there are additional agents that may improve the care for small cell. I would highlight liposomal irinotecan and the PARP inhibitors as the advances that you'll next see moving towards the clinic. But further down the road, I'm hopeful that more personalized immunotherapy efforts, such as BiTEs and cellular therapeutics against preserved neoantigens like DLL3 and GD2, may make more than incremental change and rather dramatic ones. I thank you for your kind attention.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.